By the late 1800s, more people with severe mental illness ended up in large public asylums than those places ever handled. Wards filled, staff fell behind, and long-term care turned into containment. Families and officials demanded relief. At the same time, psychiatry took shape as a medical specialty. Doctors tried to classify illnesses and prove they belonged in hospitals, not prisons. But talking cures and rest rarely changed the most violent, confused, or withdrawn patients. That gap created pressure for something physical, something decisive. If the problem looked permanent, the solution had to look mechanical. The brain became the target, and extreme ideas gained support because overcrowding made waiting feel impossible. In 1935, a Portuguese neurologist named Egas Moniz offered a bold answer to a terrifying question. What if severe mental illness could be eased by changing the brain itself? He called his operation the prefrontal leucotomy. Moniz claimed that troubling thoughts and violent agitation came from stuck pathways in the front of the brain. So he targeted those connections. By cutting them, he believed the mind could quiet down. The promise sounded simple. Early reports described patients who seemed calmer and easier to manage, and that result mattered to exhausted institutions. The idea spread fast. Doctors in other countries heard control and saw a new tool. Psychosurgery entered the mainstream conversation. By the late 1930s, the idea crossed the Atlantic. In the United States, neurologist Walter Freeman and neurosurgeon James Watts took Moniz's operation and gave it a new name, the lobotomy. The label sounded simpler, more modern. They brought it into American hospitals and began presenting it as a practical answer to problems no one else solved. For families worn down by constant crisis, it promised calm. For institutions packed with patients, it promised control. Freeman and Watts framed the procedure as a breakthrough, not a last resort. The message spread quickly. This was treatment, not experiment. And once that idea took hold, the pressure to use lobotomy on more people only grew. In the early 1940s, Walter Freeman treated lobotomy like an emergency tool that needed speed and scale. He pushed for more operations done faster on more patients. The goal shifted from careful testing to constant throughput. He promoted the procedure aggressively, presenting it as a practical answer for crowded institutions and exhausted staff. With that message, hospitals accepted it more easily. Lobotomy stopped looking experimental and started looking like standard management. But Freeman collected little long-term follow-up, so the story of what happened later stayed thin. Immediate calm counted as success. The consequences, delayed and messy, rarely entered the official record, and the practice kept spreading. In the mid-1940s, Freeman revealed a new shortcut, the transorbital lobotomy. Instead of drilling the skull in an operating room, he reached the brain through the eye socket. The promise stayed the same: speed, simplicity, control. The tool looked like an ice pick, and the method followed that logic. Fast entry, quick motion, little time spent. It meant anesthesia and surgical teams mattered less. A procedure that once felt specialized started to feel portable. With that change, the numbers rose. More institutions could do it, more doctors could attempt it, and more patients got labeled suitable. The pool widened beyond the most severe cases. A radical option shifted into a routine answer. By the late 1940s, the glowing case reports no longer matched what staff and families saw over time. Some patients looked calmer, but also blank. The change did not feel like recovery. It felt like subtraction. Doctors began recording patterns that sounded less like side effects and more like permanent damage. Seizures, incontinence, confusion, and people who could no longer work or live on their own. And sometimes patients simply died. Those outcomes spread beyond quiet hospital files. More clinicians questioned the claims, and some hospitals slowed or stopped. Newspapers and public voices started asking what improvement really meant. Doubt at last began to organize. In 1949, Egas Moniz received medicine's highest honor, the Nobel Prize. It rewarded the leucotomy as a major therapeutic advance. Overnight, a disputed operation gained the glow of official approval and global attention. Hospitals and doctors pointed to the prize as proof the method worked. Doubt looked like stubbornness. More patients got cut, not because outcomes looked better, but because the procedure now carried the weight of prestige. Critics kept pressing a harder question: what counted as improvement? Reports praised patients who stopped resisting, stopped shouting, stopped demanding. Success often meant they became quiet and manageable. Compliance replaced recovery as the metric. In the 1950s, something arrived that changed the whole equation. Doctors began using antipsychotic drugs, especially chlorpromazine, and for the first time, they could calm delusions and agitation without cutting into the brain. The effect spread fast through hospitals. A pill or injection looked safer than an irreversible operation, and it demanded less special skill. Families and staff saw patients settle without the blunt aftershock of lobotomy. Once medication became the new first choice, lobotomy lost its place almost overnight. Surgeons performed fewer operations each year. What had been sold as modern medicine's shortcut began to look like yesterday's extreme gamble. In the 1960s, the public mood shifted. Investigative reports and court challenges exposed what had been minimized for years. People left damaged, families misled, and institutions rewarded for quiet wards. Confidence in psychosurgery weakened fast. At the same time, a patient rights movement grew louder. Former patients and advocates demanded consent, records, and accountability. Hospitals faced scrutiny, and doctors faced hearings. What once sounded like progress now sounded like control. Regulators responded with tighter rules and review boards, and many programs quietly shut down. Psychosurgery did not fully disappear, but it retreated. Lobotomy remained in the public mind as a warning about medicine unchecked. By the time lobotomy faded, it stayed alive in memory. Survivors described what it took from them. Families recalled the promises that never arrived. Scandals fixed it in public history as a warning. Films and books kept repeating the same lesson. A shortcut could destroy a life. The word itself turned into an insult, a symbol of forced control. The procedure stopped sounding medical and started sounding cruel. Modern brain surgery for mental illness still existed, but it operated under tight rules. Cases stayed rare, carefully selected, and closely tracked. It offered no assembly line, no sales pitch, and no quick fix.